Nursing Care of Cognitive Disorders. Module 3, Safety, Loneliness, Suicide Risk, and Elder Abuse. In this module, we move from diagnosis to protection. Delirium and dementia increase vulnerability, physically, cognitively, emotionally, and socially. As nurses, our role expands. We are not only assessing cognition, we are preventing falls. We are identifying depression. We are assessing suicide risk. We are recognizing abuse. Protection is part of nursing care. Normal aging already affects balance, muscle strength, reflexes, and vision. When you add cognitive impairment, impaired judgment, wandering, poor insight, fall risk increases dramatically. Dementia increases fall risk approximately 3 to 4 times compared to older adults without cognitive impairment. Nearly half of persons with dementia will fall each year. Falls are not minor events. They are one of the leading causes of injury and death in older adults. Medication plays a major role. According to the Beers criteria, medications that increase fall risk include benzodiazepines, antipsychotics, antidepressants, opioids, anticholinergics like diphenhydramine. One of the most important predictors of future falls, a previous fall. If a patient has fallen before, your index of suspicion must immediately rise. Fall prevention is not just put the bed alarm on. Evidence supports exercise programs focused on balance and strength, such as Tai Chi gait training, multifactorial interventions, meaning medication review, vision assessment, environmental modification, and physical strengthening. Exercise alone reduces falls by about 23%. Even in patients with cognitive impairment. As nurses, your priorities include assess orthostatic blood pressure, review medications, evaluate vision and footwear, reduce clutter, encourage assistive devices, avoid unnecessary restraints, and remember, restraints increase agitation and delirium. Always treat the underlying cause of unsafe behavior first. Loneliness is not just emotional discomfort, it is a health risk. Older adults lose spouses, friends, mobility, independence, and sometimes purpose. Social isolation is associated with increased mortality, worsening depression, and higher suicide risk. Patients with cognitive impairment are especially vulnerable because communication becomes harder and social networks shrink. Ask about support systems. Ask who they live with. Ask who checks on them. Safety includes emotional safety. Depression in older adults often does not look like sadness. It may present as fatigue, sleep disturbance, somatic complaints, memory concerns, or irritability. Older adults, particularly older white males, have some of the highest suicide rates of any age group. Here is the NCLEX point that surprises many students. Most older adults who die by suicide do not have a previously documented mental health diagnosis. Physical illness, chronic pain, functional decline, and loss are often the primary drivers. Never assume hopelessness is normal aging. Ask directly, have you had thoughts of ending your life? Do you feel hopeless? Have you thought about how you would do it? Asking does not increase risk. It opens the door to safety. You should routinely screen older adults for depression using tools like GDS-15, PHQ-9. If question 9 on the PHQ-9 is positive, you must assess further. Protective factors matter. Suicide risk decreases when patients have strong social support, effective pain management, treated depression, limited access to lethal means. Means restriction is critical. Firearms are the most common method in older adult suicides. Counseling families about safe storage saves lives. Elder abuse includes physical abuse, emotional abuse, neglect, and financial exploitation. Cognitive impairment is a major risk factor. Only a small fraction of cases are detected. Red flags include unexplained bruising, poor hygiene, sudden financial changes, fearfulness around caregiver speaking for patient, and conflicting stories. Caregiver burnout increases risk, but burnout does not excuse abuse. You are a mandated reporter. If you suspect abuse, 1. Ensure immediate safety. 2. Interview the patient privately. 3. Document objectively. 4. Report according to institutional protocol. Document facts, not interpretations. Use exact quotes. Describe injuries precisely. Even cognitively impaired patients can disclose abuse accurately. Do not dismiss their statements. Protection is advocacy in action. For exam purposes, remember, dementia increases fall risk 3 to 4 times. Previous fall is the strongest predictor. Exercise reduces falls. Depression may present as somatic complaints. Most older adults who die by suicide have physical health stressors. Always ask directly about suicidal thoughts. Cognitive impairment increases risk for abuse. Nurses are mandated reporters and must contact protective services if abuse or neglect is suspected. Cognitive disorders increase vulnerability. Our role extends beyond recognition. We protect safety, we identify depression, we assess suicide risk, we recognize abuse, we advocate for dignity. Safety in elder care is holistic, and nursing presence, attentive, observant, and protective, makes the difference.